Hey, good morning and welcome to UroNurse. We meet every Saturday at 9 a.m. Central Time. Hey, if you're watching this on YouTube, great. Be sure to hit that subscribe button and that like button. Also, if you're watching us on Facebook, be sure to hit the like, share, and follow buttons. If this is your first time joining us, be sure to go to our website at uronurse.com where you can learn more about us, kind of see what we got going on and learn how you can be more a part of the show. And most importantly, this is the only place, or not the only place, it's the best place to find all of our past episodes because they're all up on the website, easy to find, video on demand. And boy, oh boy, do we got a lot of them here. 33 episodes. Today's going to be our 34th episode. We're rolling along. We do this every week, and so we've been going well over half a year now. We'd like to thank our sponsors, and if you're interested in finding out more information about sponsoring this show, be sure to hit that button and get information on how you can sponsor. If you're watching us on any of our formats, feel free to send a question. That's your best way to interact with us on the comment box. So Facebook, YouTube, StreamYard, all of them have comment box. All you got to do is put in your question, and we'll be glad to answer it. And this week, we've got our favorite speaker, one of our panels, our very own panelist, Dr. John Lynn, our vasectomy specialist, is going to be talking to us about vasectomies. So we're really looking forward to that. And at this point, we're going to go ahead and bring on our panelist here. So again, for those of you that may be here for the first time, my name is Vic Sinise. I'm the host of the show. Been in urology for well over 30 years, and this is my way of giving back to the community. And here's our guest speaker today, Dr. Lynn. Go ahead and introduce yourself.
Hello, everyone. I'm a private practice urologist in Gilbert, Arizona, who wants to pay it forward like what Vic is doing by sharing my experience in the business of medicine to benefit my colleagues. I'm the administrator of the Thriving Urology Practice Facebook group, where over almost 2,200 now U.S.-based urology practice personnel collaborate to improve our practices, and it's all for free. And what they say is, if it's free, I'll take 3.
Absolutely. I think that's always the best part, is having this for free is great. So we're going to just go right into our favorite stories today, and I'm going to see what favorite stories we have out there. I'm going to just share one with a quick one with you. Now, I gave a talk on AI recently. And I mean, this was only a couple weeks ago. I can't believe how much it's changed in that short time. So if you've gone and played with it, great. If you haven't, get involved in it. I mentioned that Microsoft got the ChatGPT bot going in their Bing search engine, and I've been using that. It's really cool. But I just became a early adopter for Google's search engine GPT or search AI, which is called Bard, just like the catheter, BARD. And it's right now, because probably I'm so early to it, or because they've got such big computers, it's like ChatGPT on steroids. You ask a question and it's boom, there's the answer. So it's really cool. But I'm finding out there is incorporation of AI into everything. You can, besides designing artwork, there's one now that's doing video work. There's AI. If you're using Excel spreadsheets, it'll write your spreadsheet. You want to design something in the website, it'll give you ideas for that. Slides, it'll set up your layouts and things. It's hey, what do they need us for anymore, right? Pretty soon we'll just be talking heads. So I just thought I'd share that with you.
Well, now they can create deep fake, right? They can put your face on my person and then have me act, and I'll have your face.
Yeah.
And of course, I'll have to pick up your mannerisms to make it look real.
Exactly. Well, that'll be hard. The other thing I heard is the voice is getting to be really good. So it's hard to tell. And I mentioned I got those robocalls a while back, and you're wondering, is it a robot or is it real? And it's hard to tell these days.
Yeah, you can ask the weather, you can ask where they're located, but eventually I think they'll figure out how to fake that too.
Oh yeah. It's gonna be. I think it's gonna be that good versus bad, evil versus the angelic. So for those of you that are watching, be sure to send in any questions that you have on the comment box. We'll be glad to take those before the show starts. Otherwise, we'll get rolling into our show. Go ahead, John.
Yeah, find the comments box, because I'm going to ask you to answer some questions. So find the comments box in StreamYard, the platform that you're using right now. I'll be asking you some questions.
There we go. Different. We're going to do an interactive talk
Oh,
today.
of course. Audience
All right.
participation. That's
Sounds
what
good.
matters. Yeah, because I could just sit here and talk all I want, but if I can't answer your questions, it's kind of meaningless to you. So one of my favorite stories, well, this is regarding a BPH patient, a gentleman with an enlarged prostate. He had horrible symptoms, and he said, well, something happened to me. That's why I'm here seeing you today in the office. And he said, I have had trouble urinating and horrible urinary urgency and frequency for a long time. He was driving up to Prescott, which is a couple of hours away from where I am right now in Gilbert, Arizona. So he was driving up, and all of a sudden he gets that typical urge, that horrible urge that I really got to go, and he couldn't hold it. He didn't have anywhere to relieve himself, so he pulled off to the side of the road on the right side of the freeway. He opened up the passenger and it's a 4-door sedan, front passenger door and the rear passenger door. And he kind of squatted between those areas and was peeing there because he couldn't hold his urine. Well, guess what? The highway patrol officer pulled up behind his vehicle thinking that it's a distress vehicle, tried to help him out and saw him peeing. Well, what is that? That's indecent exposure. So the officer said, you know what? You could be cited for indecent exposure and be on the sex offenders list. And that is when my patient said, that's it. I gotta get help. So the moral of the story is, do not wait so long until it gets to that point before you seek help.
Exactly. Wow. That's crazy. And even interesting how he had the doors open, trying to, how many times you drive by and you see some guy just standing on the side of the road taking a leak, no coverage at all. And at least this guy had the wherewithal to try to cover himself up a bit, but don't get in trouble, have the procedure. And so many different procedures now to treat BPH, it can be done in the office.
Well, a lot of people don't realize that when you go to a primary care doctor, their toolbox is counseling, ordering labs, ordering imaging, and prescribing medication. And we are all biased. And I tell my patients that you come to a urologist, our bias, our personal bias, our inherent bias is to cut, is to operate. So I always try to keep that bias in check whenever I'm seeing patients. The primary care doctor that you see are more likely to prescribe a medication when there are other options available that will cure the underlying problem instead of putting a Band-Aid, which is a medication.
Yeah.
And
it's that old adage, if your only tool is a hammer, everything's got to look like a nail, right?
Yeah. So you always have to keep that in mind as a practitioner and as a patient yourself utilizing health services.
Yeah. Good point. Well, I'm not seeing any comments coming through. Are you ready to let it roll on vasectomies?
Let's go.
All right. Let me put you up here in the solo spot. There you go.
And very good. All right. It is my pleasure to talk about vasectomies, one of my favorite topics in urology. I happen to do a lot of these, and it became a passion over time. I did not go into urology thinking that I would be doing a lot of vasectomies. So let's talk about this. And there we go. All right. I'm also known as the experimentator, self-proclaimed experimentator. Although in today's presentation, there are only 21 slides. Be assured that there are fewer than 20 words in the entire deck. So sit back, relax, and just enjoy. And I am going to ask you to answer some questions just coming up. So make sure you are ready to answer these questions. Make sure you find the comment box. All right. I'm going to start with the story of Tom and Jennifer. Tom is an exec in a mergers and acquisitions company, and he had just closed a huge deal. He's going to be getting a huge bonus, and he's going to be getting a promotion. So he calls Jennifer, his wife, and says, hey, I closed this great deal. I'm going to be getting a bonus. Guess what? I'm also getting a promotion. Let's go out tonight and celebrate. So he calls Jennifer. Jennifer quickly arranges a sitter for the 3 kids. They go out and have a wonderful, beautiful meal. taking a little bit of libations. They get a little giddy. They get home. The sitter says, hey, all 3 kids are asleep. And so what do? They get a little jiggy, a little bit of frisky, and they up consummating their marriage, their wedding. Now they're happy having 3 kids. That's their limit. They don't want to have any more. So during intercourse, in the back of their minds, they're always worried, am I going to get pregnant? Am I going to get Jennifer pregnant? Now, Tom did not use a condom, and he used what a lot of my patients tell me. They use the pull-out method. I call it pull and pray. Pray that you don't get your wife pregnant or your partner pregnant. So he used the pull and pray method, and that kind of takes away from the experience so that you can be fully engaged with your partner during that encounter. So vasectomy is a way for you to engage in worry-free sex with your partner. If you're done having kids, or if you never had any children and having children is not in the cards for you, and you are absolutely sure that you don't want to have more kids, then vasectomy is the way to go. All right. This is going to be an interactive presentation. I'm going to be asking some questions. So again, find the comments section and answer these questions if you can. So first question, I have a few for you. First question, who has assisted your doctors in vasectomies or has seen a vasectomy performed? Who has assisted your docs or has seen a vasectomy performed? I want to hear. You can just hit yes or no in the comments and let me know what your experience has been. And that's all right. Very good. Yes, yes. And I'm not talking about your personal vasectomy. I'm talking about vasectomies that you've seen or you've assisted. Very good. Neil and Susie and Linda. Very good. Thank you very much, Ron. All right. Second question. Does your doctor perform the procedure by himself or has assistance by an MA, medical assistant, or a nurse or an APP, advanced practice provider? Or sometimes maybe he switches out, both. So self, help, or both. Do it by himself, do it with assistance, or both. RN prep, very good. RN prep. And yeah. And assistant with medical assistant or LPN, very good. Yeah, nurse, very good. Self. Some do and some don't. So both, very good. Excellent. Very good. All right. Last question. How long does it take your doctors to perform a vasectomy? How many minutes? I hope it's just minutes. How many minutes? So just kind of put that in the comments. I want to kind of gauge how long it takes some of your docs to perform this procedure. How many minutes does it take for your docs? 10 minutes? Excellent. 10 minutes. Excellent. Very experienced docs. Excellent. All right. I'm going to move on to the next topic here. Let's talk about efficiency or efficacy, effectiveness of vasectomy. Vasectomy is performed about 500,000 times annually just in the US alone. When it comes to effectiveness in preventing pregnancies, short of not having sex, short of abstinence, it is the most effective way to prevent pregnancies. Vasectomy is 99.95% effective. Failure rate of 1 in 2,000 is extremely, extremely effective. Sometimes, well, you want to make sure that you are completely done having kids because it is a permanent form of sterilization. It is not something where you can just say, well, you know, I changed my mind. Can I go back? It's going to be difficult. 99.95% effective. Now, that said, it is not a way to avoid sexually transmitted infections. It only prevents pregnancies, but it does not prevent you from catching something bad if you are indiscriminate, shall we say. All right. How the procedure is done and the experience of the patient and how long it takes, as we already found out. It depends on the experience of the surgeon. I will tell you that when I first started doing vasectomies, I sucked at it. During training, nobody wanted to do vasectomies because there's a small case. We didn't concentrate on vasectomies. But then when it came into private practice, a lot of people wanted vasectomy. So I remember my first vasectomy, it took me 30 minutes. I was literally sweating. I made 2 incisions and I was wearing these big magnifying glasses to perform the procedure. Now it is so much better because of experience. So your mileage will vary depending on the experience of the surgeon, experience of the staff, and how the procedure is performed, how long it took, and also the patient experience. Not all physicians do it the same way. And according to the 2012 updated 2015 AUA guidelines regarding vasectomies, the surgeon or the urologist, typically the urologist, should do the method that gives the best patient outcomes and the best patient experience. When it comes to patient selection, it is important to let the patients know that this is a permanent sterilization procedure. If the patient comes in and he starts talking about reversal or sperm banking, I try extra hard to talk him out of it. It seems like if they're thinking about going back or changing the sterilization so that they can have kids again, then are they really sure that they want to have a permanent sterilization procedure? So in that situation, I try to talk them out of it. And I saw someone mention that if there's a age limit under which or above which I do not perform a vasectomy. Well, I'll tell you, I have patients in the 70s coming in for a vasectomy and someone as young as 18 coming in for a vasectomy. Some men are just absolutely sure that they do not want to have kids. And I do not discriminate based on age. So I'm age agnostic. If I try my darndest, even for that young patient, I try to tell them, hey, you know what? When you're 14 years old, just think about what you thought you knew. And now think about when you're 21 or you're 18, how things have changed. How do you know after you make this permanent life-changing decision that you're not going to change your mind in the future? So I try everything I can to talk them out of a permanent sterilization procedure. But if they're dead set on having it done, then I'm not going to prevent them from doing it. There was several years ago, there was a 21-year-old who came in for permanent sterilization with his parents. He was deathly afraid of getting a woman pregnant. So he actually attempted suicide not once, but twice. In that situation, I gladly performed his vasectomy because it literally meant life or death to him. So I do not discriminate based on age. I also do not obtain spousal consent. I don't ask the wife whether or not the man should have or can have a vasectomy. Likewise, a woman does not require a male's consent to achieve sterilization to obtain tubal ligation, the female equivalent of a male vasectomy. So I do not obtain consent from the opposite partner, if you will. All right, when it comes to vasectomies, some people have said, I can do it virtually, seeing that patient the first time via telemedicine and not seeing the patient in person. My bias is that I want to see the patient in person. I want to meet the patient. Yes, there's a lot of social media content out there about my vasectomies, but there's nothing better than physically seeing the patient and establishing that know, like, and trust factor. Yes, the patient's already there for undesired fertility, for me to talk about other techniques to avoid pregnancy, and then ultimately us deciding on a vasectomy. But I want to make sure, I want to be able to see the patient. I want to be able to gauge or judge his vibe, if you will, because that is extremely important. I think of it as kind of like dating. That initial, you want to set the expectations. You want to make sure that they know what to expect from the experience and the long-term consequences. So I try to make sure that I see the patient in person at that first meeting in real life and not do it virtually. In addition, getting accurate history from the patient is also very important. I want to make sure that this patient tells me about their past surgical history. Have they had an orchidopexy? Have they had a hydrocolectomy, spermatocolectomy? Did they have an undescended testis that they require surgery? Did they have prior trauma to the scrotum? Or have they had a prior vasectomy and then a subsequent reversal, and now they want a vasectomy? So these are all important histories for me to obtain, because that tells me, okay, what am I going to get when I finally examine the scrotum? Also, there's some guys who are extremely anxious. They come in, they show up, you can just sense their anxiety. Those patients, I want to be extra careful. I want to talk about various different ways of anesthesia, and we'll talk about that in a second. So I want to make sure that they can tolerate the procedure. Even though technically I can do the procedure, I want to make sure they have a great experience. So making sure that they can tolerate the procedure is another reason that I see the patient. It's in person, because it's difficult through a camera to judge how the patient is going to respond on the day of the procedure. But in person, it's really easy to figure that out. When the patient comes in initially, before I even see the patient, my amazing medical assistants have already gotten vital signs on this patient. I can't tell you how many young guys, typical age of vasectomy patients, about mid-30s. I have diagnosed so many guys with uncontrolled, undiagnosed, asymptomatic hypertension. And that is why they call this a silent killer. Nothing happens to him until one day, stroke, heart attack, and they check out. Well, I can't have him do that. This is a young guy who's productive in society, who has a family, typically kids that he has to support, and also a wife who's a companion, and maybe they support each other in today's day and age, right? Not just the man supports the wife. The wife sometimes works as well. But I need to make sure that I do everything I can to preserve that nuclear family, to make sure that he's working. In addition, I jokingly tell the patients, I need you to continue to work so that you can pay into my retirement, right? When I finally retire. So I have caught a lot of guys with uncontrolled hypertension through this intake process. So many guys with diastolic pressures in over 100, systolic pressures in the 170s and 180s, completely asymptomatic, coming in, walking, no headache, no shortness of breath, no chest pain. I offer to refer them to a cardiologist that same day. I have a cardiology practice right across the street from where I am. Or I strongly encourage them to see a primary care doc immediately to get that blood pressure under control, because I do not want to be performing a vasectomy, an elective procedure, on this gentleman and have him stroke out on my table, right? It's never happened, but it's my responsibility to make sure that he gets the best care possible. So seeing that patient in real person, in real life, allows me to get vital signs and assess his health status. All right. And then during the examination, I can praise the patient, because in the last couple of years, I performed over 2,200 vasectomies. So to say that I'm a scrotal connoisseur will be an understatement. When the patient undoes his underwear, I can look at the scrotum and examine him, and I can say, oh my gosh, you've got a nice scrotum. Because from a vasectomist, a loose scrotum in a man who's typically not obese, I hope a lot of my patients are obese and overweight, but for the patient who's thin, who has nice loose scrotum, I call that a medical student scrotum, because the scrotum is so easy that a medical student can perform the vasectomy procedure. So being able to examine the patient, being able to make sure that there are actually two vas deferens, two vasa, one on each side, is important. Sometimes there's a congenital absence of vas deferens when I examine the patient. So if that's the case, then I need to know beforehand and let the patients know. If the patient has a tight scrotum, or it's difficult to isolate the vas deferens, then I let them know that I may struggle a little bit. Even despite my vast experience, you may feel a little bit more pressure and a little bit more tugging during the procedure. So I want to set the expectations at the very outset before the day of the procedure. All right, let's talk about technique, how the procedure is done. Now, again, it varies by surgeon. It varies by the urologist. Even though I can say that I performed a no scalpel technique, some urologists use a scalpel. Some urologists make 2 openings in the scrotum to perform the procedure. I make a single puncture without using a scalpel. So your mileage, again, your mileage will vary depending on the comfort level of the surgeon in performing a certain technique versus someone else. And I will tell you, when it comes to vasectomies or any surgery for that matter, experience means a lot. Experience of the surgeon matters a lot. The other thing that I see a lot of patients who have seen other urologists and then they come in for their vasectomy evaluation. I have heard some patients tell me that the urologist that he saw earlier said that they put his legs up in a lithotomy position to perform a vasectomy. Again, your experience varies depending on how the surgeon is trained, but the way I perform vasectomies is that the patient's lying on his back. And I think that's mostly how most urologists perform vasectomy. This is the patient lying flat on his back. He does not need to be in a frog leg position. So I find it interesting. But again, your mileage will vary depending on the surgeon performing the procedure. I don't know where some of the patients get this information, but there's no laser involved when it comes to vasectomies. I'm not aware of a way of how laser is in any way involved in the performance of vasectomies. So no laser involved in vasectomies. Yes, manscaping. This is something that sometimes is feared, and it's a big worry, believe it or not, for some of my men. Now, a lot of you guys and gals may be thinking, oh my gosh, are you kidding me? Everyone I know manscapes. Well, not all of them do. When you've examined as many scrotums as I have, I will tell you not everyone manscapes. I tell my patients manscaping could be done with a sideburn trimmer, with scissors, or with razor, however you want to do it, but you do not want to use epilation. You do not want to use Nair. You don't need to have your hair follicles lasered off, even though I have seen guys who have had cosmetic laser surgery on their scrotums, not for vasectomy, but they've had their hair removed permanently using laser. You don't need to go overboard when it comes to manscaping. You can just use shears, scissors, something simple, nothing fancy. And my staff, they're so smart, because when someone does a manscape and they show up for their vasectomy, even despite the fact that we have it on a handout, if they don't manscape and they show up, then we have to do it. And it's definitely not as comfortable as possible. We jokingly tell the patients that if you make us do it, we're going to charge you extra. But on a handout that we give our patients, we highlight the area where we remind them that they have to shave and make sure that they show up cleanly shaven. All right. When it comes to anesthesia, so many different ways to make sure that the patient has the best experience possible. It doesn't matter how we do it. Verbal anesthesia. Everyone gets verbal anesthesia, meaning conversation if they wish, or I have a conversation with my medical assistant during the procedure. Everyone gets local anesthetic in addition to verbal anesthesia. So they get numbing medication and they get conversation. And then after that, there's a variety of ways to make sure the patient's comfortable. It could range from nothing, absolutely nothing at all, to oral Valium, to nitrous oxide or laughing gas, to the very anxious patient who needs IV sedation. In Arizona, I have the luxury of having an anesthesiologist come into my office and then starting an IV on a patient, putting the patient under twilight, if you will, and then performing the procedure in just a few minutes. That's for the very anxious patient who has to lay down on the floor, believe it or not, or lie down on the table immediately after I examine the patient. These are the super anxious guys for whom I offer IV sedation in the office. And then for the difficult anatomy, someone with previous surgery, I know it's going to be a struggle. General anesthesia is also offered so that he has the best experience with the best outcome possible. All right, when it comes to instruments, this is all I use. 6 pieces of instruments, not including the suture, not including the local anesthetic. The blue instruments, other than the one on the left side, the blue instruments are all made of titanium. Very strong metal that is also very lightweight. So starting from the top, that's a needle driver. And then the next instrument is a vase clamp. It encircles the vase. And then at the one below that is the vase dissector. It has the pointy end, and that's the instrument that I use to make the puncture. And then the last one, the bottommost one, are a pair of iris scissors. I never touch that. My assistant uses that. And then the instrument on the right side is a pair of Atsons with teeth. And then the left side instrument is a pair of bipolar forceps. All right, this is going to be a short video of a vasectomy that I performed about a year ago. This happens to be a physician who was gracious enough for me to capture this vasectomy procedure. Now, this video is being played back at 2x the speed because I don't want to belabor the point. I'm going to kind of briefly narrate the right side of vasectomy, and let's show you how this is done. The patient's head is on your left, feet are on the right. You're looking at it from my perspective as I'm doing the procedure. Initially, we'll isolate the vas deferens, and this is the most difficult part of the procedure. Finding the vas deferens is the most difficult part of the procedure. So the right side of the procedure, the right vas deferens is initially palpated. I try to isolate the vas, and that's the most difficult part of the procedure, is finding the vas deferens. I tell patients that this is all by feel, and that's why I don't think a robot will ever replace a vasectomy procedure. A robot can never perform this autonomously because you have to manually find it, and not everyone has the same anatomy. I'm giving infiltrating local anesthetic right here, and I use a 26 gauge needle. Only a total of 2 to 3 cc's is needed. I use the vasectomy dissector to make a single puncture around the vas deferens. With my left hand, I'm isolating the vas, and then this is the ring clamp that I use to capture the vas. And with my left hand, I confirm that I actually have the vas. And if you notice, the instruments are being passed to me. My eyes almost never are off where I'm operating, and that's how I'm able to do this so efficiently. And the little dissection, now I have the loop of vas isolated, dissect the external spermatic fascia off the vas deferens, the blood vessels underneath. I use the bipolar cautery to divide and cauterize the ends of the vas deferens. And I can use the same cautery to stop any sort of ooze. And then I use a piece of suture to perform what's called fascial interposition. I use the patient's own tissue to cover up the abdominal end of the vas deferens. And keep in mind, this is being played back at 2x the speed, just to make sure that we get through everything. So the typical procedure takes me less than 5 minutes. Even though on a handout that I give to the patients, I tell the patients that it's going to take less than 10 minutes, but I like to under-promise and over-deliver. Because there's such a huge demand for my services here in the Gilbert, Arizona area and the surrounding, actually the entire state. Again, a couple of years, I performed over 2,200 vasectomies. I'm not aware of any urologist who performs more vasectomies than I do in Arizona. Because I've done so many of these, there's a huge demand. Occasionally, we have to hold what's called vasectopaloozas. On a Saturday morning, we do nothing but vasectomies. Sometimes once a month, sometimes every other month, just to catch up on the volume. In February, last month, we performed 18 vasectomies on a Saturday morning. And we've done as many as 27. For giggles, I decided to time myself to see how fast am I really doing these procedures. So among those 18 vasectomies, it took about 3 minutes and 37 seconds on average to perform each procedure. And that success, that efficiency, how quickly I can get it all done, is because I'm a little anal when it comes to trying to figure out what is the fastest and the best way to do this procedure. Also, I have an amazing assistant helping me, handing me the instruments when I do this procedure. I'm not taking my eyes off the field when I do this procedure. Anytime you take your eyes off the field, I don't care if you're doing ureteroscopy or open surgery or robotic surgery, you have to reorient yourself, and that microsecond adds up. So I try to keep my eyes on the field and have an assistant hand me all the instruments. Having done so many, it's like I reach out my hand and the right instrument is handed to me in the correct orientation at the right distance away from where I'm going to use it. That, if you perseverate, if you are a student of lean principles, it's going to allow you to perform this procedure extremely quickly. The fastest I've done among the 18 vasectomies that morning was 2 minutes, 54.6 seconds. And that's a very ideal scrotum with everything going perfectly smoothly. All right. Let's move on here. After the vasectomy, the recovery varies by individual. We tell the patients, don't shower the first day and no soaking the wound. You want to pat dry. You may resume protected sexual activity about a week after the procedure. And for my patients who are white-collar workers, I tell them a day and a half, you can get back to work. For my folks who work from home, I tell him that you can go back to work the same day because you can be in a Zoom meeting. I say that you could be having a party up top. A business up top and party down below. You can be applying ice. You can be wearing scrotal support. Nobody is the wiser when it comes to your recovery if you work from home. And for my construction workers, police officers, firefighters, UPS delivery folks, I tell him that you want to take about 3 to 4 days off. For my police, I see a lot of first responders. They usually work 3 on or 4 on and 3 to 4 off. I tell him to come in right after the last shift so I can perform the procedure, and he usually has 3 to 4 days off without having to take any sick days. And generally, they do great. And we tell the patients that you want to listen to your body. Even though we tell you a day and a half, 3 days, 4 days, 7 days, listen to your body. If your body is saying that you can't tolerate it, or if you're feeling a little unease, a little bit of pressure, then obviously don't go overboard. We also caution patients that you're going to feel great most likely right after the procedure. Don't overdo it. All right. You want to kind of listen. Those who follow our instructions and they follow our directions, they do great. But I've also had patients who had a vasectomy and the next day they go to the lake and they soak the wound in the lake and they call us wondering, gee, it's all red and swollen. I wonder why. So be smart about it. After the vasectomy, we tell the patients that you are absolutely not yet sterile until a semen analysis that is done 3 months and 30 ejaculations later, showing no sperm. 3 months and 30 ejaculations later. We use a lab called Fellow. It's a mail-in kit. The patient takes the kit home, provides a sample at home in the comfort and privacy of his home, sends the container in to the laboratory, and he gets the results back in 2 to 3 days. Extremely easy and convenient for the patient. Whatever you want to do, you want to make it easy for the patient to take the action that you desired. Remove any and all friction whenever possible. That's how you get the best compliance. And of course, we have to talk about the rare complications after vasectomy. Recanalization or reconnection of the tubes is a possibility. Chronic pain occurs in 1-2% at the very most. Thankfully, in my hands, it's less than 1%. Testicular damage is extremely rare. The only time that I've had a patient who had testicular damage was a guy who had an infection, which is another potential complication. And he had an infection in his left scrotum, and because of that severe infection, he did suffer testicular atrophy on that affected side. That's the only case of an infected vasectomy where it led to a loss of a testicle after thousands of vasectomies that I performed. So anytime you do any sort of procedure, there's always a remote risk of complications, and infection is one of them. And it can be devastating in this situation. Hematoma, having a little bit of blood collection in the scrotum after the procedure, is a possibility. Sperm granuloma, having a little swelling, a tiny little scar area in the area of the vasectomy. Sperm granuloma is also a concern. Some of my patients who had a vasectomy done elsewhere, where the urologist used titanium clips, I have had some of those patients complain to me that they can feel the clips. But whether or not they could feel the clips, I think the mental impression for them is that there's a foreign body in the scrotum. So sometimes they feel that and they're unhappy about being able to feel that clip. And lastly, inflammation of the epididymis, also known as epididymitis, can occur. Usually that is taken care of with conservative measures such as anti-inflammatories, ice, scrotal support, and rest. Rarely do we have to surgically intervene to take care of epididymitis. So let's talk about the role of the nurse, medical assistant, and APP, advanced practice provider, such as a nurse practitioner or PA. They are the key to my success. The utility, as you guys have mentioned, depends on the surgeon performing the procedure. I use my MA extensively in the performance of vasectomies. They make my life easy. They're the reason, and my entire staff, they make me so that I can't relate to burnout that is being mentioned by other urologists, which is apparently very pervasive. Two things. Number one, I have full control of my practice environment. And number two, I make sure that everyone is operating at the top of their license. I, as the urologist, am the most expensive employee in a practice. Everyone needs to be working at the top of the license. And that phrase is being thrown around a lot. But what does that mean? That means that I, as the urologist, should not be doing anything that somebody else can be doing. Meaning I should only do things that only I have to do and only I must do. A lot of urologists who are doing administrivia that should be done by somebody else are probably getting a lot of the burnout experience that they're feeling. So the MAs do everything. They answer questions before the patient even shows up at the appointment. They answer questions after they make the appointment, and they have questions regarding the experience. During the procedure, my medical assistants help me from beginning to end. And lastly, after the procedure, the patients often have questions, and my staff answers those questions for me on my behalf. So I use my MAs, and they are absolutely invaluable in my success when it comes to vasectomies. Your mileage may vary. Your physicians may utilize assistants differently, but that's the way I do it, and I've had pretty good success with it. All right, there are a lot of common misconceptions. Let's talk about some of these. The picture on the right is similar to the picture that I have on the handout that I give to my patients, and the patients receive this handout. It's available on our website, and they have the handout given to them the day of the procedure. They read it. They sometimes look at this picture and say, oh my gosh, are my balls going to be hanging loose and just kind of swimming around in my scrotum? No. No, it's not going to be hanging loose attached to nothing. It is going to be still surrounded by cremasteric muscles, multiple fascial layers attached to lymphatics, attached to blood vessel. It is not going to be hanging loose. And let's talk about some of the frequently asked questions when it comes to vasectomies. This is also on a handout that I give to my patients. So number one, some patients have asked, do you see an increase in vasectomy volume during March Madness? For the average urologist, I would say yes, you would see an increase in vasectomies during March Madness. We're in the middle of March Madness right now. In my situation, we do so many vasectomies throughout the entire year. There's a backlog of patients who drive from hours away to seek my services. there's never a shortage of vasectomy patients. So I personally do not see an increase in vasectomy volume during March Madness. When I was first starting out, yes, but not anymore. Something else, actually, I was interviewed recently, 2 to 3 weeks ago, by a local NBC affiliate regarding my impression after the Dobbs decision, Dobbs versus Jackson, also known as the reversal of the Roe versus Wade decision by the Supreme Court last year. I was interviewed regarding my take on what's been happening relative to vasectomy. Some people may say, well, they saw an increase in the number of vasectomies being performed, or number of men asking for vasectomy procedures. But in my situation, it's still a lot of men. But one thing that I've noticed, and it's persistent, it's still the same way now, is that I am seeing a lot more men coming in for their sterilization services who have never had any children. These are men who either are single, who never wanted kids. Now they're making the decision to undergo a permanent sterilization procedure by taking responsibility, or that man who is married in a relationship and the couple absolutely do not want to have any kids. They do not want to take any chances. So the number of men with no children coming in for vasectomies, that number has increased, and that has stayed elevated in my practice. So that's the only thing that I've noticed different after the passage of the Dobbs decision. All right. Other things that could, other frequently asked questions are, guys will ask me, is there any difference in my sexual performance, erections, orgasms, ejaculation? And also, is there any difference in the amount of the semen that comes out in my jizz, or whatever it is, whatever you want to call it? Nothing changes after a vasectomy relative to your sexual ability or the quantity of semen coming out. Now, if the spouse is in the exam room with the patient, I will tell her that I cannot vouch for the taste of the semen. So anyway, got to have a little humor in vasectomy in urology, right? Also, there's no difference in sex drive, in libido. A lot of people think, oh my gosh, am I going to be neutered or spayed? No, nothing happens to your testosterone, no change in testosterone, because testosterone is produced by the testicles and carried through the bloodstream. I'm not touching your bloodstream. I'm touching the tube that conducts sperm out of the testicle into the ejaculatory ducts. So no change. And there are no metal clips when I perform this procedure. I do not use any titanium clips. That's one of the questions that some patients have asked me. Full recovery from the procedure, typically within 7 days. But again, your mileage may vary depending on the individual, depending on the surgeon, depending on the patient. And also, there's no change in ability to void. I'm not touching the urethra. After vasectomy, you should not notice any difference in your ability to void. All right, this is a very short video that I created several years ago about vasectomies. You can go to vasectomythemovie.com if you want, or you can go to experminator.com, alljuicenoc.com. So let's watch this short movie trailer. Soon to be an Academy Award-winning movie.
He was longing for an alternative to the condom conundrum. She was tired of the agony of excess estrogen. They were both searching for a better way. What they found would change their lives forever. Dr. John Lynn, Sunrise Urology, the vasectomy. Their love was accidental. They learned that the results didn't have to be.
Yes, that's right. Coming soon. All right. Very good. And if you haven't had enough of our conversation or discussion, feel free to connect with me via social media. You can find me on most of the popular platforms at JCLINMD. And I'm also on the Thriving Urology Practice Facebook group. Scan that QR code. It'll take you directly there. It is free. And there's a couple of thousand urology practices in the U.S. Urology folks who practice in the U.S., who work in urology practice in the U.S. in that group. If you are a vendor watching this video, do not bother joining. We are not going to take you. We want to have a safe environment where we can talk good about you, and talk badly about you if your service is not good. So I'm going to ask for any questions or comments that you may have. I'm going to try to scroll through the comments and see if I missed any. I want to say, lastly, thank you so much for the privilege of your time. Back to you, Vic.
Hey, well, thanks. That was a great presentation. I did start the scroll going. If there's any comments, questions, concerns, feel free to go ahead and put those into the comment box. We'll be glad to answer those. We did get some reactions here. Wow, from Ashley, who also threw some emojis in there too.
I love those.
So thanks, Ashley, for your comments. So welcome, Andrea joined us too. So that's nice to see you here. I had a comment to make. You were really nice at mentioning how much you depend on your staff, which I think is really important. And so one of the things, I've probably assisted in thousands and thousands of vasectomies. I like the small incision approach. I've seen everything from, get my fingers where I can see them, that big of an incision to the stab wounds. The people obviously heal much better from a smaller incision. Now, from my standpoint, what I have found works really well for the urologist, you had talked about that perfect sac, is I always heat the prep. I always heat the prep kit before I scrub. So I'm doing the prep ahead of time. I always make sure that that's at least warm temperature, and I figured that all out, how to get it to that exact temperature. Huge difference. Now, of course, if my physician is kind of gotten on my bad side, I might use that ice cold scrub.
I love it. Well,
So
thankfully,
stay on my good side.
Yeah, thankfully we're in Arizona, and the temperature usually is pretty warm out here.
So we do have some questions coming in. We'll go ahead and bring those up here. Linda Davis says, how do you use APPs? Good question.
That's a great question. I personally do not use APPs. That's part of my brand differentiator. You will see a physician at every single visit. Now, I would say majority, but probably half of the practices out there now use an APP. So I do not personally use an APP.
Gotcha. Ashley said, can a nurse practitioner see the patient for consult first, then schedule the vasectomy with the MD?
Absolutely, yes. Absolutely, yes. Now, it's important for the APP to communicate clearly with the urologist, because if there's an unusual anatomy, you need to let the urologist know, or somehow note that in your document, in your encounter, so that he knows what to expect going into the procedure. Or if there's an unusual anatomy, better yet, have the physician see the patient incident 2, that's a billing term, incident 2, and examine the patient so that appropriate expectations can be set. And also the appropriate anesthetic can be chosen. It could be a patient, this could be a patient that requires IV sedation versus general anesthesia if the anatomy is that unusual.
Yeah, very good. And we have another question. Susie says, do you follow up on the semen analysis for every patient?
We absolutely tell the patients that you have to undergo a semen analysis. Now, and we tell them that they have to have it done. Whether or not they do it, that's up to them. Do we follow up as far as you had a vasectomy here and we haven't gotten the results of a semen analysis? Yes, we do follow up on every single one of the patients. There's a big long Excel sheet that we keep track of every single patient who had a vasectomy, who had a semen analysis or have not had a semen analysis. My staff, unfortunately, has to spend a lot of time babysitting a lot of patients to make sure they have appropriate follow-up. And that's the same thing no matter what you do. If you order a PSA, if you ask the patient to come back, if you ask the patient to obtain an imaging study, you always want to make sure that follow-up is done, because I know someone, a urologist, who ordered an imaging study and a renal mass was found, turned out to be kidney cancer. It was never disclosed to the patient. She suffered injury. He was sued, and he had to pay out. So after every lab request, it is incumbent on the practice to make sure that appropriate follow-up is done. And if the patient doesn't follow up, you document the efforts that you took for the patient to follow up. Because actually the only claim that I know that is not covered by malpractice was a vasectomy, a post-vasectomy pregnancy. So wrongful birth, that's the name of the claim, wrongful birth, where the malpractice claim insurance did not cover adequately for this wrongful birth situation. So follow-up, extremely important.
Very good. Nils asks, is there a way to examine and know if the individual would be one of those 0.5 percenters?
0.05% of failure? No, I wish there was. If that was the case, I would just concentrate on that guy and make sure I do something special to make sure, I don't know, maybe excise the segment or fascial interpose both ends. I don't know. I wish there was. And I wish there's a way to predict who is going to have chronic pain, who is going to have epididymitis. There's just no way. And thankfully, the incidence is extremely low.
Thank you, Dr. Lin, for that presentation. I just had a quick fun question. I've heard of patients doing vasectomy cakes, vasectomy parties after their procedure. Have any of your patients done that?
They sometimes come in with their own T-shirts brought in by their spouses. They show me pictures of the kits, vasectomy kit that their spouse has created. I personally, we have been giving out vasectomy T-shirts forever. So if you Vic, if you don't mind giving me the wide shot. There are two lemons back there. So my T-shirt is a black T-shirt with two lemons in the front. And on top of it, it says all juice, no seed. And on the back of the T-shirt, it says all juice, no seed in small letters with the lemons in the background. And it says experimentator.com across it.
Yeah, we, on our Christmas show, when I was showing all the different presents, one of the things Amazon sells are these underwear that with these ice packs that you can stuff in there to keep the testicles cooled off. I thought that's not a bad idea because we always tell people to, keep it iced down. It's preventing swelling is much better than trying to deal with swelling.
Yeah, definitely. And what I tell patients is that you want to buy frozen peas and frozen corn and put them in baggies, put them on 15 minutes on, 15 minutes off. And you want to make sure you save the frozen corns and peas for your in-laws during the holidays.
Now, my favorite one is telling them to get a nice cold beer out of the fridge and put that between their legs. And I said, it's okay if you drink a little bit of it too.
I love
Linda Davis's question to us is, are you having patients hold NSAIDs prior to the procedure?
Sure. If the patient takes it chronically, we try to encourage them to do it. But if they forget, it's not going to make any difference because literally the puncture is like 3 to 5 millimeters. It is tiny. And we make sure that it's hemostatic at the end of the procedure. So even if they take NSAIDs, that's more of a ideal to achieve. If they forget, we don't stop the procedure. We don't have the patient not undergo the procedure if they tell us that they forgot to withhold the NSAIDs.
Now, if that was daily NSAID use, or you would still go ahead, or
yeah, daily NSAID use. Yeah, if they forget, it's not a big deal.
Comment here from Rebecca. Fantastic talk. Thank you very much. Can't argue that. I think you were very thorough in our discussion. Again, it's been great. I just like to thank you for doing the talk. We always like to have the guy who's done the most, right? Talk about the way you can do it fast. And I do agree with that. Having that assistant there handing off so you're not changing your visual. We do something similar when we do prostate biopsies where the ultrasound tech, which is myself, is separate from the doctor taking the biopsy sample. So we're not switching where the probe is aimed because you're taking your eye off to aim a needle. So I think anything where you keep your concentration makes a difference.
Well, I'm going to have to disagree with you there. The way the transrectal ultrasound done, I operate the ultrasound and I operate the device to obtain biopsies. I think that is the most efficient way instead of having somebody manipulate the other. Are you talking about you operating the probe?
Yep.
No, I operate the probe because that's how I aim. and then with my right hand, I'm obtaining the sample. So we disagree in that.
We can disagree on that, but it does work. Hey, we're going to keep going here to finish up our program. Oops, I got to take over the front here. Next week, be sure to join us. We have Lisa Bucheman is going to be joining us from the WellSpec company, talking about their different products for intermittent catheterization. So we're looking forward to that next week. Also going to be trying this as a remote. I'm going to be in Denver giving the talk. For those of you that have not had enough of us, which we know there's a few of you out there, the after party will happen. Last week we tried StreamYard to do the after party. The problem is once I shut down the program, all the panelists can still talk, and we chatted a little bit afterwards and never got on the StreamYard. So I'm going to stick with the Zoom process. So if you want to join us, go to our website, hit the after party button. It's going to take you into the Zoom room like usual. You guys can start talking. You'll be able to go right in there and get ready, and we'll join you as soon as we finish with this. With that, I would like to thank again all of our panelists for joining us today. It was, again, Dr. Lynn, great talk. Andrea, thanks for coming in, and hope to see some of you for the after party. Otherwise, we'll see you next week, and from high up on altitude in Denver, and I don't like the high altitude, so if I'm a little short-winded, you'll know why. But have a great day, everybody. We'll see you next week.
All right. See you in the after party.